Baroness, thank you so much for kicking us off with such a wonderful reminder of love and devotion and how that is central to so many of us. It's for Muslims around the world, Eid, as an end to Hajj, the annual pilgrimage, which is a commemoration of the life of the Prophet Ibrahim and his son Ismail, who within so many of our traditions represent the most epic of devotion, love, and sacrifice. And what I want to do over the course of the next half an hour or so is to talk about some of the work that I've been doing with Muslim communities in the UK, and particularly clinicians, as they traverse different forms of devotion, both to their faith, their profession, as well as their communities. And what I will try to do is work through this process through some examples, some stories. But before I do that, I want to acknowledge both the Centre of Islamic Studies at the University of Cambridge, as well as the Ethox Centre, who've been wonderful supporters of the work that I've been doing, and incredibly sympathetic to and patient to a nosy researcher like myself, who's always wanting to ask awkward questions and get into spaces and work with people who wouldn't otherwise get to participate in research. It's the last day of our meetings, and so I understand there may be some fatigue. There may be a desire to nod off, and that's absolutely fine. I'm giving you permission to do so. But before you do, I will summarize what I'm going to say, after which point you can do as you please. Why should we think about the moral universe of Muslim clinicians? The first is that in the UK, there's a growing number of Muslim clinicians, and a growing number of Muslim clinicians who express a deep devotion to Islam. And what I've been wanting to do is to understand the manifestation of this devotion. And some of that occurs seamlessly in their practice, but there are instances in which this juxtaposition of devotion to faith, devotion to profession leads to challenges. And it's that sort of space as an ethicist that I'm interested in investigating further. And one of the sorts of ideas that I've been mulling over, and this isn't half-baked, it's not quite got in the oven yet, and so I'm looking to all of you to help me develop this further, is when we encounter this juxtaposition, it results in discomfort, and usually discomfort is a productive space. A productive space for learning, a productive space for engagement, a productive space for enrichment. Yet what we find through the data that I've collated is there is an absence of that productivity when we encounter this discomfort. And some of that is about the sorts of barriers that exist in Muslim healthcare professionals being able to be morally integrated persons in the way that we've been discussing over the last couple of days. Some of that is about the types of discrimination that they face, but also a need for scholarship within the tradition itself, and the sorts of difficulties Muslim clinicians encounter when they interface with not just medical authority, but also religious authority. And one of the things that I'm very, very keen on is developing robust moral spaces. And as an ethicist, I see that there is, of course, a broader commitment in that regard when we look at ethics committees and the role of clinical ethics advisory groups. But when it comes to different moral resources and the complex moral universe of clinicians playing out, there is an absence of those sorts of plural and constructive moral spaces. What are the consequences of these sorts of challenges? And some of that is threaded throughout our discussions, the sorts of corrosions, the sorts of moral injury. The other is that it makes work and the care of patients difficult, and I'll share with you some of the examples around that. But the part of this that troubles me the most is without productive discomfort and disagreement, what we lack is an absence of the enrichment of ethics as a field in itself. And I'm hoping that we can talk a little bit more about that. With that summary, you can, with permission, nod off. A little bit about the data. Some of the UK government data on the NHS workforce shows that a significant number of our doctors, as well as our broader healthcare professionals, come from ethnic minority communities, either as people who've trained in the UK, or a significant number of whom are part of the migrant workforce in the UK. Some work that's been done by the Muslim Council of Britain shows that a significant proportion of that ethnic minority workforce ascribe to the Islamic faith. Before I move on, is anyone an expert in Islamic theology and ethics in the room? I can say what I want then. This is brilliant. And what we see is, although we don't have a precise number for how many Muslim clinicians work in the NHS or even in private facilities in both, the British Islamic Medical Association, which is the largest membership organisation for Muslim clinicians, had a ballpark figure of 7% a few years ago. More updated figures seem to suggest it's as high as 10%. And in some parts of the country, that's going to be higher still. And I'll tell you a little bit about that demographic variation shortly. When we think about the moral universe of Muslim healthcare practitioners, it's incredibly important to consider the different levels of normativity that exist within Islam. Muslims consider the Quran as the word of God and the ultimate authority for any kind of decision-making, be that private or public, as mundane as how to wash oneself or how to eat, and as profound as death and dying and how to care for the ill. The tradition of the Prophet Muhammad that has been collated in narrations that are collectively known as hadith are also an important source. Some of you may have come across this as being referred to as the sunnah. What I would say is that the sunnah is the practical embodiment, but the hadith are the collections themselves. And the Quran and hadith are considered the primary sources that are then interpreted by the second level through jurisprudence, theology, tasawwuf or mysticism. And for Muslim laity, these are incredibly important sources of learning, meaning making, and practice. But what's important to understand is the interaction between Muslim people as well as these sorts of sources. And many of you will recognize that although the Quran and Hadith are incredibly rich moral guides, they don't provide a read-off of what we should do when we're thinking about withholding and withdrawal of life-sustaining treatment. And so interpretation of scripture is incredibly important, and that's where the role of religious authority is paramount. And the issuing of fatwa or legal edicts. And this is where religious scholars who are deemed to have authority look at normative sources when they encounter questions from Muslims, and they deliberate on what the sources say and they issue a verdict. And the way in which fatwa work is that they provide a very particular answer to a given context. And so what we find within Islamic jurisprudence is a plethora of views. And I'll give you an example later of the consequences of that sort of pluralism, which is an incredibly important feature of Islam, but can also lead to its own sort of challenges, particularly when religious authority from different parts of the world become parachuted in different contexts. So that gives you a little bit of a flavor about Islam and broadly Islamic ethics. When we're looking at the healthcare space and the sorts of resources that Muslim clinicians may use, there is a burgeoning of Islamic bioethics, or this relationship between bioethical questions and the Islamic tradition. There is a discussion and debate in the literature and amongst experts whether Islamic bioethics is actually a field, or whether it's a case study of bioethics as a broad field, and what Muslims provide is a richer example of how different moral resources may come together. We can have a wider discussion about that. It's something that particularly interests me. But what I wanted to share with you are some of these references that are only increasing in number. Many of the scholars and healthcare professionals who are associated with this work come from the Middle East, some come from the UK, as well as the US. But a lot of this work has been happening in the Middle East, particularly since the 80s, when questions about reproductive technologies, cloning, genomics entered the consciousness of not just religious scholars, but governments in those parts of the world. And they were keen to develop guidance and interact very, very directly with medical sciences. A little bit closer to home, in addition to those sorts of theoretical guides, there are practical spaces that Muslim clinicians turn to. I mentioned some of these earlier. The British Islamic Medical Association has been increasing its membership and is it has been doing a lot of work over the pandemic and prior to that in engaging with Muslim communities, but also has set up its own journal. The Centre for Islam and Medicine, the logo of which is in the middle, was established just over a decade ago, and CIM's work was predominantly to look at this interface of Islamic theology and ethics within the biomedical domain. Al-Balagh Academy has been set up by a doctor, Rafaqat Rashid, who is also an Islamic scholar in his own right. And interestingly, the Balagh Academy has an increasing number of students that complete their Islamic scholarship program from within the healthcare sphere. And so you see this interest amongst Muslim clinicians of all kinds to equip themselves with the expertise and the literacy to traverse not only their professional space, but also the sorts of religious commitments that they may have. Finally, I'd be remiss to not mention the initiative of Islam and Medicine that's been set up by a wonderful friend and colleague, Asim Padella, who is a trailblazer in this space, recognizing in the US a need for Muslim healthcare professionals to have resources, to have guidance, and they've been inundated with demand for their work, not just amongst professionals, but communities more broadly. Given this background, you may be wondering, what do I do? I've spent a number of years investigating how the experiences of Muslims and the embodiment of Islam plays out within healthcare and particularly within palliative and end-of-life care. And what I wanted to look at was whether or not Islam was important in the deliberations that patients and families and clinicians make. And if Islam is important, then how it manifests, and how our recognition of these sorts of realities can enrich broader discussions and debates within medical ethics and more broadly bioethics. Lots of literature around this. I have syntheses for those of you who are interested. The other thing that I've been doing is, and this will give you an insight into my psychological state and what I do in my free time. I look at court judgments and LexisNexis, which is an encyclopedia of legal cases. I'm seeing lots of people laughing at me in the audience. Yeah, you're allowed to laugh. And what's incredibly important to recognize, and Ilora was touching on this last night, is an uptick in disagreements between families, healthcare professionals, and the legislature about decision-making at the end of life. I've been looking in particular at cases involving Muslim families, and the reason I've not managed to publish it yet is every 6 months when I update the search to make sure it's fresh, I encounter more cases and I'm just like, ooh, I need to include this. But if any of you are interested in being a part of this endeavor, please do let me know. It's a very, very rich data source and some really important themes coming out in terms of the sorts of value judgments that are implicit and explicit within clinical decision-making, but also in the work that judges do, and how that becomes incredibly difficult for families and communities. And that maybe there is a role for us to demystify some of that deliberation in order to prevent the sort of erosion that we're seeing in our institutions. But the sort of thing that I will be focusing on for the rest of my presentation is the empirical work that I've been doing, interviews with different stakeholders. And most of the work has happened in London and Birmingham. That's because when we looked at census data through the Muslim Council of Britain, those are the two parts of the country that have the highest Muslim population. And so I was like, recruitment will be easier, but it'll also be useful to understand how Islam plays out in contexts where Muslims are larger in number. London has a population as high as 10% of its population fill the census as them being Muslim. In Birmingham, it's as high as 20%. So 1 in 5 people in Birmingham are Muslim. And so that's really important when we consider the makeup of healthcare professionals, but also the communities that they serve. I'm not going to show you my 25 pages of en vivo codes, but there's a summary of some of the themes that have emerged about medical interventions themselves, particularly around withholding and withdrawal of care, that we will delve into a little bit, as well as values, particularly around hope and acceptance, and that for Muslim patients and families, it's not about hope and despair. It's about these concurrent virtues that they're grappling with and how that's a manifestation of taqwa or commitment in God consciousness. But what I will focus on for the last, the remainder of my talk, and Ashley will tell me that my time management is horrendous and you'll tell me to shut up at some point, which is absolutely fine, is this part of it, the role of personal faith in the sorts of decision-making and conversations at the end of life. Why am I interested in this? Don't buy the book, it's too expensive. If my publisher hears this, I'm going to get into trouble. But one of the reasons that I'm interested in this question of personal faith is I encountered this in a way that was unexpected when I was doing my DPhil research, looking at Islam within biomedical research ethics, predominantly speaking to researchers, research ethics committee members, guideline developers in Malaysia and Iran. And one of the things that cropped up in that work is professionals in these sorts of spaces don't read out from guidelines, don't exist in a linearity of, I'm now a professional, and so I'm following this guidance. I'm now at home, and I'm living a different sort of moral deliberation. All of these different sources coexist within them, and grappling with these becomes incredibly, incredibly difficult. And so I wanted to look more closer to home, where Islam isn't the majority religion, and how that plays out for healthcare professionals. For some, it was very clear that their faith is deeply, deeply important to them in terms of why it is they entered the profession itself, what defines their continuing commitment, and how that manifests when they carry out their day-to-day practice. A few more examples of some clinicians saying, I don't think I walk into work and I'm governed simply by secular beliefs. Islam and being Muslim is too ingrained within me. Some clinicians weren't so sure. And it was interesting that as our conversation in this particular interview continued, there was a little bit of a tension about how their faith played out in their work. This sense of guilt when clinicians are thinking about whether their faith should have a role in their thinking. And I'll tell you a little bit more about this interviewee in a brief while. I mentioned earlier that I will tell you a little bit about some of the challenges that exist in Muslim clinicians being morally integrated persons. And some of that is to do with this juxtaposition with religious authority. Muslims tend to fall within two broad categories as Sunnis or Shias. This categorization is theologically and politically rooted. When Muhammad died, there was tensions about who should inherit his position as leader of the Muslim community. Sunnis predominantly chose his friend and confidant Abu Bakr. Shias thought that mantle should very much be for the Prophet's nephew Ali. And there is a difference in how religious authority is understood within these two branches of Islam, and I won't delve into that in too much detail, but if anybody's interested, we can discuss that in the Q&A. But for Shias in particular, religious authority is incredibly important through this manifestation of taqlid, or essentially following the guidance of somebody who's considered an expert in religion in a way that's full. It's a handing over of one's decisions to a certain extent. And some of the clinicians said that although they considered this very, very important, it was difficult. And one of my reflections of why that may be the case is that often the scholars that have this authority and are relied on aren't commonly residing in the UK. And so they're not necessarily familiar with the context and the sorts of ethical questions that the clinicians themselves may be facing. And this leads to this tension in terms of the textual and contextual parts of healthcare professionals playing out this sort of dissonance. And I wanted to flag some of the text in this, this discomfort, this feeling of shame, a recognition of hypocrisy, verbalizing the sort of moral injury that we've been discussing over the last few days. Another aspect of how this sort of discomfort plays out is in understandings of care and what we mean by healthcare as well as basic care. And there's been a lot of work in the UK to distinguish legally the status of artificial nutrition and hydration, and there's precedent which was very, very important in enabling clinicians to withdraw nutrition and hydration, particularly in cases where patients are in a persistent vegetative state. But when cases don't fall in that category, deliberation is incredibly difficult, incredibly fraught. And this is an example of a cardiologist reflecting on their experience of caring for patients where one of her seniors diagnosed someone as being at the end of life. And at the time, there was a preponderance of applying what is called the Liverpool Care Pathway. In its origins, an incredibly important commitment to palliative care within acute medical settings, but in its application, sadly, an intervention that didn't work so well, to put it mildly. And one of the reasons is displayed on in the text, where clinicians thought withdrawing feeding as well as hydration was a way not to prolong someone's dying. And in acute settings, there being very little space for medical teams to have a discussion about what different team members thought, as well as within the hierarchy, what the feelings were. And junior clinicians, nurses, still describe their difficulties about those sorts of conversations and decisions. And she described to me, in this conversation very vividly, of running around the ward when she was a junior doctor, trying to hook patients back onto drips because they'd spent 2 weeks without any sort of intervention, and that being incredibly injurious for her, but there being very little space to discuss with seniors and other team members this tension of the status of nutrition and hydration at the end of life. And some of the reasons for why she thinks what she thinks being rooted in her personal beliefs about basic care. What we find is one of the reasons why these sorts of tensions play out is that the evidence base is unclear. So when I was training, there were huge concerns about fluids ending up in people's lungs, causing difficulty with their breathing. And when a review was done, they found that actually the evidence was equivocal in terms of what the implications of hydration are at the end of life. And there is an interventional study that is now ongoing, for those of you who are interested, that is beginning to show that actually hydrating patients at the end of life may actually help in sort of alleviating some of their symptoms. And so dealing with this sort of uncertainty, dealing with the realities of medical hierarchy is incredibly fraught, alongside clinicians themselves having very particular views about nutrition and hydration, and that these subjects are incredibly emotive. Food and drink are ways in which we are loved and we show love. And that manifests itself in the sorts of experiences that clinicians have shared with me. I'm running out of time, but I hope the sorts of cases and examples that I've shared with you give you a flavour of some of the sorts of tensions and challenges that are playing out. And I hope that we can discuss a little bit more about how we can generate productive spaces for discomfort and disagreement, these moral spaces within which plurality can exist in a way that can enrich medical ethics and bioethics further. Thank you so much.